Please welcome NCQA Executive Vice President, Quality Measurement and Research Group, Dr. Eric Schneider.
Hi, good afternoon, everyone. It's great to see so many people here in Orlando. We are really delighted to be joined today by Dr. Joe Betancourt. Joe is one of the preeminent leaders in healthcare. And until recently, Joe was Senior Vice President of the Equity and Community Health at the Massachusetts General Hospital. Last year, Joe became President of the Commonwealth Fund, a 105-year-old philanthropy dedicated to bringing about a high-performing healthcare system. And I just learned that Joe also was recently elected to the National Academy of Medicine in the United States. So please join me in welcoming Dr. Joe Betancourt. So Joe, thanks for joining us for the fireside chat. We don't have the fireside, but right. It's good enough. You don't want it in Florida. Joe, you have been always provided primary care throughout your career, even as you've been leading efforts to improve equity at all levels of healthcare organizations. And how does your experience as a clinician inform your work on health equity?
Yeah, well, first of all, thank you for the kind invitation, and thank you all for choosing us when it's nice, beautiful weather outside. I appreciate it and look forward to this conversation. So, I think clearly being a primary care provider has been a big influence in how I have attempted to take this work forward. I'd probably, though, take a step back and talk a bit about kind of the lived experience that drives my passion for this work. So I'm originally from Puerto Rico, grew up in New York City in a bilingual bicultural home, served as an interpreter for my grandmother. Really didn't come from a family who had gone to higher education. And I say that only to say that lived experience, the challenges of navigating a lot of different systems, but certainly the healthcare system was one that I experienced through my family. And then getting a chance to do my medical training in places like Newark, New Jersey, New York City, where I'd say that every day it became very clear to me that we were failing in our approach to delivering high quality care to anyone from anywhere at any time. And I'd say that my desire to remain in clinical practice, even to this day, is driven by the fact that that's really the daily living laboratory. I mean, to me, that's what gives me ideas. It allows me to have empathy for the challenges that people are facing. It allows me to, I think, really stay engaged. And, those experiences, I think, for me, this journey, both lived experience and clinical experience, has helped shape a lot of my perspectives. I guess I'd end by saying that working in large health systems as well, I think, has been helpful. I mean, I understand a lot about the thinking, the strategy, what people do, and particularly when it relates to regulation and policy, the types of hoops that people will jump to find loopholes in regulation and policy, as well as the things they'll do to adhere to regulation and policy. So, as a clinician, I learn from my colleagues, from my patients, from being a student of the system, and also being part of that ecosystem. And I think certainly for me in this role at the Commonwealth Fund, I think we need to lead with experience, expertise, humility, but really understand that the solutions aren't in the ivory tower. And so I think that primary care experience that I still have today will drive our future.
Yeah, thank you for emphasizing that lived experience. It's so important to not lose touch with that as we try to move into these other arenas of leadership, policy, management, and trying to drive quality. You've also been a scholar of health equity. You played a key role in the Institute of Medicine's unequal treatment, which was one of the early steps on this journey that the U.S. health system has been on, published now 20 years ago, I think.
Yeah, 20th anniversary this year.
Yeah. As a longtime scholar of health equity, how would you grade U.S. progress on healthcare equity?
Yeah, it's interesting. I was thinking a lot about this because there's no doubt that I began this work in the late 90s, early 2000s. the kind of seminal effort that I was involved in was the Institute of Medicine report, Unequal Treatment, released in 2003. We celebrate the 20-year anniversary of that report, which I would argue, by the way, if those of you who aren't familiar with it, there's no need to reinvent the wheel as we pursue quality, safety, value, and health equity. Sadly, in many ways, the recommendations from that IOM report, which is now 20 years old, are as good today as they were then, and they are a litany of, I think, unfulfilled promises. I think to answer your question about how we've gone, I think from when I began this work in the early 2000s, I think about this work in chapters, right? So I'd say that the Institute of Medicine report on equal treatment comes out, unequivocally says, yes, we see differences in the quality of care that patients receive above and beyond the contributions of the social determinants, above and beyond issues related to access to care, but really, in the exam rooms, in the emergency departments, of our healthcare system across the country. And, we acknowledge that there's no one solution and no one suspect. But as you might imagine, this issue's not new. There were a lot of reports that had preceded the IOM report, but that IOM report added a certain imprimatur, as the IOM does with Crossing the Quality Chasm to Err is Human. And I think all those reports were released right around the same time. And so it drew newfound attention. And so I'd say quickly that the first chapter after 2002 was one of progressive leaders, early adopters. I'd say, some work on data collection, some work on strategic planning committees. Really, I'd say it was those early adopters and progressive leaders where we saw some progress. And that progress went on from about 2003 to about 2006, 7, 8, when the conversation of healthcare reform starts to emerge. And that conversation, although very important, because we always acknowledge that access to care was a key contributor to disparities, what started to happen was it started to kind of draw attention away from disparities in equity and more to access, rightfully so, but I would say to some degree at the expense of the work that we were doing on disparities. One good thing that really comes out of that ACA work is a much greater attention to the social drivers. But I would say that there was also people who at that time were saying, see, we always said it was all about the social drivers. And we were saying, no, disparities are due to the social drivers and access and disparities in care. So that chapter, I think, was one where we tried to hold our footing around the ACA and also saw a lot of benefits that I think overall will help disparities in health outcomes. Shortly after that, we see this real push towards value. And I think that was an exciting time, and it still is. We're in the midst of that push right now. But this fundamental notion that we're going to pay for quality of services, not quantity, and we're going to bring team-based care to what we're doing, and all the innovation that value brought, we were able to say, look, if you care about value, eliminating disparities is a high-value target. It's care that's not reliable, not consistent, costs more, poor quality. So it was the definition of low-value care. And so we got a lot of momentum there, and I think that was exciting. That's when the pandemic hits. Yeah. And certainly both the murder of George Floyd and the COVID pandemic and its disproportionate impact on communities of color opened up this gigantic window for a discernment, a discussion around structural racism, around health equity, that people like me who are really kind of working at the system level to drive change now had a much bigger runway, and we tried to grab a lot of ground. And when I say grab ground, really dig in and build more systems to move this from what I would say over the course of years had been heavy on aspiration, but very light on execution. The rigor of execution had really been missing. And so, that was an exciting time. And so we're now in this kind of post-pandemic chapter where I think we all see that there's a fair amount of pushback. This has been politicized, and I think we're trying to hold our ground and say, no, this is about quality, safety, value. Equity is a key component of quality. Crossing the Quality Chasm said that 20 years ago. And so this isn't about good or bad actors. This isn't about politics. This is about making sure that we're delivering on our promise of high quality care for everyone. And so that's where we are now. And I do think value-based payment, that conversation is helpful for us.
That's great. Yeah, I want to come back to the health equity action agenda in a moment. But I didn't want to leave the Commonwealth Fund's Mirror report off the table. Commonwealth Fund has been a real driver in understanding how the U.S. healthcare system compares to other nations, and the U.S. has, over 20 years, really ranked last in the Mirror rankings on several dimensions, notably access and equity, although it's defined a little differently in the Commonwealth Fund report. So I wanted to learn a little bit about how the Commonwealth Fund is driving toward greater equity in the U.S. healthcare system.
Yeah, and look, there's no doubt that report year after year tells us we spend the most and we get the least, right? We spend the most compared to other OECD nations. We have the lowest life expectancy, highest infant mortality, most chronic disease. The list goes on. And so it's not a proud list to be on. And I think that the good news is that the Commonwealth Fund, as you know, having spent time there yourself, it was built in 1918 on the premise that resources and philanthropy needed to be leveraged to meet the needs of our most vulnerable. And so equity is really in the structure and in the DNA of the Commonwealth Fund, going back to our first investments in things like public health departments, rural hospitals, medical schools in urban areas, the whole APP movement, stimulated by really cutting edge work from the Commonwealth Fund. It's history that I've learned that has been phenomenal. And the ACA work. So I would argue all of that, equity has been centered in all of those discussions. I had the great privilege of benefiting from one of the Commonwealth Fund's programs that really aimed to tackle another issue of equity, which is diversity in the healthcare leadership, through the leadership of Karen Davis at that time, her foresight to say we need to develop more minority healthcare leaders, created the Commonwealth Fund Harvard University Fellowship in Minority Health Policy. I did that in 1997. I'd say that was a major step forward. That's still one of our biggest investments, a fellowship that aims to train individuals who want to really lead in health equity. And that's a program that's not new. It's been around for a while. And so I guess, certainly today, we still have, we have an advancing health equity program, which is our largest among our 8 programs, one. I'd say, second, we really try to cross-cut equity in all of our other programs, Medicaid, Medicare, delivery system reform, cost control, coverage, access, and tracking. We try to find the equity components of that. And in our health equity portfolio, we focus on 3 areas: equity and health system change, equity and healthcare policy, and kind of securing leadership buy-in. And we have a particular focus on maternal health. And so that's where we are now. And certainly I'm excited to grow that portfolio and think about what we could do in a strategic way. But I'm pleased to say that we're building on a very strong history of a commitment to equity in all ways. We have a strong portfolio now that I inherited. I'm part of that, and I look forward to building that some more.
That's really great. It struck me as I understood the origins of the Commonwealth Fund much better. It came out of a pandemic, the 1918 influenza pandemic.
That's right.
And revisiting that history in the midst of the 2020 experience was pretty eye-opening.
Yeah.
And the equity implications, as you say, it was really rooted in public health.
Yeah.
Going to policy, and I hope people will check out the Commonwealth Fund website because it's just a treasure trove of policy insights. Unfortunately, several states have been enacting policies that can make it hard for health systems to achieve equitable health outcomes. And I know the fund works a lot with state policymakers. How are you addressing equity in the state context?
Yeah, it's a great question. I mean, I think you mentioned Mirror Mirror, which shows that, again, we're don't have a good look on that list, right? Spend the most, get the least. When you look under the hood, though, and you look at our state scorecard, you're also able to see the very significant differences among states. And what should jump out at you is that state health policy really matters. Mm-hmm. Certainly, our work at the federal health policy side is important, but as you might imagine, you could literally track, the equity issue and disparities, by states, and the states that you might imagine that, quite frankly, and this is, an apolitical statement, but I'd say have a different perspective around investments in the social safety net, have had a different perspective around Medicaid expansion, have had a different perspective around their reaction to the Dobbs decision. All those things, I think, play out in our maps as you might expect them to do. So, we work very closely with states. We have, we're very pleased to have been one among a chorus of, I think, many who we'd like to believe help get North Carolina across, the finish line on Medicaid expansion, still working in other areas there. We work very closely with NASHB and thinking about how we bring leaders from states together. And at the end of the day, what we find is that a lot of these, not the electeds, but individuals who are working in state government, they have a lot of connection. The problems are very similar. They're trying to find solutions. And quite frankly, the politics gets in the way. But these are good people who want to do the right thing. Yeah. And so we're trying to figure out strategic ways to work with states to do all that, to improve access, improve coverage, do more around payment reform, because certainly we've seen value-based payment has narrowed disparities in the state where I've been for 20 some odd years in Massachusetts. We've seen that. So both value-based payment and our kind of almost universal coverage made a significant difference. So you could hold up Massachusetts and which always ranks first, and then you could look up at some of the lower performers, and you'll see that the state health policy matters. There's other factors, obviously, around states, but this notion of politics being local does play out in what we see around state health policy and outcomes above and beyond equity, but coverage and life expectancy as an example.
Yeah. No, I've always found it inspiring that Medicaid directors working in the 50 states, all trying to achieve better health outcomes for their populations with different political environments to work in and funding supply. So as you say, everyone's trying to do the right thing by the people that they're serving, which is really inspiring. NCQA has been playing in that space too. And actually I want to just prompt the audience. If you have questions, would like to come to the mics, we'll probably, I have 2 more questions and then we can move to audience questions. So I just want people to be aware of that opportunity. In recent years, we launched a health equity accreditation program, and it's actually a series of programs actually that reflect the journey around health equity. And this year, for the first time, we're requiring stratified reporting of selected HEDIS measures by race and ethnicity. Yeah. We're making a bet that transparency around equity and pointing out which plans are doing better at achieving equitable outcomes for their members. We're betting that transparency will motivate health plans to action. This is coming back to the point about how we execute on action. What do you think 3 or 4 things are that health plans could be doing with the accreditation work, the measurement and reporting? What can they be doing to advance health equity?
Yeah, and I'd say it's essential. And Eric, I've had the pleasure of working with NCQA for a bunch of years, maybe now, since 2007. I just had a chance to see Jennifer D'Alessandro, who is a real amazing partner. NCQA has been at this early. Actually, NCQA in the early 2000s, after the IOM report, created these multicultural health plan awards to really recognize health plans who were innovating in the health equity space. So this is not new, and I think that was the carrot approach, and it was really exciting. Again, I would put that in the kind of storming and norming chapter of the previous illustration that I was providing, and so that was exciting. And so to come back now with accreditation standards is really critical, and I'll get to that in a moment. But I want to talk about a little bit of the journey from then to now. Our partnership with NCQA really solidified some more in 2007. When I was up at Mass General, I ran a place called the Disparity Solutions Center, and we created something called the Disparities Leadership Program. And the idea here is that, we wanted to really work with operating healthcare systems, hospitals, health plans, health centers, to really build a plan in this space, to really execute, to bring that rigor of execution, goals, timelines, milestones, accountability, resources, and the like. And that program allowed us on a year-after-year basis to bring in a cohort of anywhere between 20 and 40 leaders. NCQA provided the accreditation for that program. But I share that to say that we started that program in 2007, and by the time I left the Disparity Solutions Center in 2019, we'd work with well over 300 healthcare leaders representing about 400 hospitals. We probably work with about another 150 health plan leaders, about 50 health plans across the country. And so I guess what I'm sharing now doesn't come from just making it up. Yeah. We've worked hand in hand with large health plans, kind of more regional, more local, state-based. And I think there are a key set of ingredients that we saw in that work with those health plans that were really essential. The one is, the standard saw that you can't manage what you don't measure. Knowing who your members are provides you the best way to serve them. And I would argue that knowing their racial, ethnic, and cultural background is helpful. And so that race, ethnicity data piece, I think, is really foundational. That being said, I've worked with many health plans who haven't had the ability to collect that data. Health plans who've made it optional for patients to put it in our portal. I think we provided a grant with Grant Makers in Health and NCQA to look at data in that space. So, in as much as you can, pushing the envelope on getting that data is the number one I think, priority, and that's foundational because, and I do believe the use of big data is going to allow us to kind of tailor and customize services to our members. That data alone in and of itself is not good enough. It's what we do with that data that's most important. And of course, measuring our performance is really what it's all about. Identifying hotspots, thinking about ways in which we might deploy different strategies. And I've worked with a lot of health plans over the years who've developed culturally competent care management programs, made sure their member services have individuals of different cultural and linguistic backgrounds. So there's been a lot of, I call it more than nibbling, I'd say, kind of building out of different pieces, but they haven't been really connected. And I think the holy grail is taking data, measuring your performance, and really developing interventions. Now, bring it to the accreditation program. I think after 20 years of this journey, I really do feel like what's going to get us, over the hump here is really leveraging this as part of payment and regulation accreditation. I'm convinced that we've squeezed as much out of the lemons to get the lemonade that is the people who come at this willingly. And then I think to get that last bump, we are going to really need to bring a series of carrots and sticks, I think, to this through both payment, regulation, accreditation. And so I really appreciate NCQA's effort, and I encourage people to go ahead and go through that process because it identifies hotspots. And I would argue CMS is on this. I mean, we're seeing this with Medicare Advantage. We're seeing this, they are very bullish around how to really build equity and move it from nice to do to need to do. So this is coming, and I would just encourage people to be a little planful because what you all are doing, what CMS will do, and what others are doing in the ecosystem, I think, will drive more rigor into this space.
That's great. It really reinforces a theme that came up in a plenary presentation earlier about alignment and how do we achieve alignment and get all of the participants in the system activated. We're going to stand up so that we can take audience questions. So I have another question if there isn't one in the audience, but I see one there.
Hi, my name's Liz Hogan with High Labs. I want to actually continue the conversation that you just ended on about big data. I think that AI has been talked about as a potential part of the solution for equitable healthcare, but it's kind of got pros and cons, right? On the one hand, it can be an objective, kind of indifferent source of truth, and on the other hand, it's very often trained on homogeneous data sets that undermine its ability to be a positive move towards health equity. So just generally, would you say you're more pessimistic or optimistic about AI's role?
Yeah, it's a great question. I mean, I think there's no doubt that AI is coming here to stay. It's going to get, it's changing day by day. So this is a reality, I think, that we're going to need to respect. And it's actually, as we think about the Commonwealth Fund's priorities in the years to come, this is one that we're thinking about, can we play a role in this space? I'll say that I believe it has incredible potential, no doubt. I think that the equity community is a bit concerned and a bit worried about how AI might be used, and the kind of premise is that if it's built with the same biases, if you will, that we see in our day-to-day healthcare system, that then this will just reify that going forward at great peril. And so I do think that right now, what the health equity community has taken is a fairly defensive posture, which is to say, how do we make sure that equity, these issues aren't perpetuated and exacerbated through the use of artificial intelligence? And I think that clearly there are opportunities for us to change our mindset and think about other ways in there which there might be very important applications for this. It will absolutely require that people with lived experience, clinical experience, that community-based experience be involved in those processes. Now, there's going to be people who are innovating to try to answer this question, okay, equity and AI. I would argue that none of that work will really be meaningful and take root if we don't include some of the thinkers that have been at this for a long time and could really benefit from the return on investment that intersection will provide.
Great. Thank you for that question. I think there's another question there in the audience. Please.
Yes, hello. I'm Dr. Dimitri Malloy. I'm a chief medical officer for a health plan in Washington. Having a little fan-out moment with Dr. Betancourt because when I studied at Robert Wood Johnson Clinical Scholars, I read so much of your work, and you spoke to us, and I think your work has been great in this area for so many years, so thank you for that.
Thank you.
In particular, your notes around health plans, what you just said, I really appreciated that. I'm wondering if you can say a little bit more about connecting some of the things you talked about with health plans, to specifically that point around leveraging leaders and leader buy-in, because I think I'm trying to work sort of in that space a little bit, even with our healthcare authorities and with some of the state agencies and things like that, around maternal health, around other sort of areas, and just trying to get some of that leader buy-in. So if you can connect the dots a little bit there.
Yeah, it's a great question. I think one of the things I've lamented in the past, in the years that I worked in the Disparities Leadership Program, was the silos that, if broken, I felt, we'd really be able to move exponentially on this issue. So, just even locally, when I was in my role at Mass General, we were trying to figure out ways in which we could work with health plans and share some data. And there were certain firewalls that prevented that. There was other firewalls that prevented some data sharing and collaboration between the public health system and the state board and the like. So I'd say two things on that. One, clearly we do need people like you and health plans to kind of, bring these things forward and to think about these creative solutions. And so I do believe that having those diverse set of experiences in the health plan space is going to be very valuable. We've seen it over the years, and I think it's been a drip, not nearly the way I think we'd like it, but I think some of the real innovators have had that experience and have added to that. So that'd be one. I'd say the second is, that's been a tough nut to crack, is these firewalls, and I think that they do come at, equity is an expense, is an unintended consequence, in that, some of the data sharing, some of the strategies. I had often thought that even in certain markets, health plans might collaborate and create a commons where you might think about powering up navigators or healthcare coaches so that everybody benefits. Because that was the other thing that I faced working with a lot of health plans, was like, what's our penetration in this market or that market? And is it worth investing here because we don't have that many members? So there was a series of things in our work with health plans, which were realities that I think worked against what we were trying to accomplish with health equity. But you call out, I think, a couple. And I don't know that there are easy solutions, but I think in so much as we can incentivize those collaborations and catalyze them, I think that's really where big progress will be made. And it's like so many other areas in healthcare where silos are not optimal, right? And so I think health equity is a great example of that.
That's great, thank you.
Thank you.
Thank you for that question. One more question, community-based organizations, they seem to be an afterthought in our $4 trillion healthcare system, but they're so vital to the social needs that you described earlier.
Yeah, absolutely. So, in my previous role, I oversaw community health at Mass General, and I'd say, the one big observation I have in that space is, and this is more a local reflection, but with a national kind of observation or suggestion, is that there's no doubt that we have come to a really incredible place on our understanding of the social influencers, social drivers, social determinants. Those words are being used interchangeably now. I think some more progressive thought is social influencers. And I think that's really important. I'd say one, obviously, we can't, the healthcare system can't solve this on their own. This is in large part depending on local political environment and requires public-private partnerships. But in the midst of that, I'd say reckoning around the importance of the social drivers, we did see the emergence of what I would argue are brokers. And by brokers, I mean, I identify your social needs, and then I have a quick way to point you to the community-based organization that's going to help you with food insecurity, housing insecurity, you name it. And whereas I think that air traffic control is incredibly important, more often than not, no assessment was made as to whether those community-based organizations had the resources or the capacity to meet those needs. Yeah. So many upstream are checking that box. We've referred people, we've sent them, we've pushed them, we've linked them. And linkage is not only not enough, but if those organizations are understaffed and under-resourced, I'd argue you're creating more trouble for them. So my ask would be, as we think about the social drivers, and as we think about our now responsibility to collect data on social needs and try to help meet social needs, that we really treat respectfully our community-based organization partners and make sure they are powered up to do that work that we report out that's being done and that we believe they should do, because I would argue they're under incredible strain. And so treating them with dignity, giving them resources, creating real partnership opposed to pointing you to that place for food insecurity, I think that's where we need to go in this space.
Great. Well, that's a great closing. I had the pleasure for many years of Joe lecturing in my quality improvement course on health equity issues. I'm still learning from Joe. Joe, thank you so much for spending time with us today.
I appreciate that.
Really
Thank you
great
all.
to see you.
Appreciate it. Thank you.